So, good afternoon, dear students. Today's topic is specific and non-specific inflammatory diseases of joints. So, what's the difference between specific and unspecific arthritis? So, when we speak about specific arthritis, we have specific antigen, a specific agent that leads to this arthritis. And unspecific arthritis are common like rheumatic, rheumatoid, reactive arthritis, because of different response of our immune system. So biogenic infection of joints or septic arthritis is a bacterial infection of the joint, which causes an intense inflammatory reaction with migration of polymorphonuclear leukocytes and subsequent release of proteolytic enzymes. This could lead to destruction of articular cartilage and later of full joint. Most common agents are Staphylococcus aureus, Streptococcus, Pneumococcus, Escherichia coli, aerobic gram-negative roots, and different polymicrobiological factors. Predisposing factors are trauma, diabetes, steroid therapy, malignancy. More common sites of involvement are knee, after it hip, elbow, shoulder, and in children, knee and hip, like in simple sites. So first of all, about lab studies. So joint aspirate and synovial fluid analysis. This is the most accurate diagnostics for septic arthritis, and using it, you could know the proper agent and choose antibiotics to treat this. In some cases, you could provide biopsy of the synovium and examine histologically. In laboratory investigation, you could see increasing of white blood cells and erythrocyte sedimentation rate, see reactive protein, etc. Treatment. First of all, you must know that you must provide a few times of aspiration of joint fluid, and you must fix this joint in a functionally well position using different orthoses or plastic cast. After you got the response for those organisms that cause this arthritis, you could provide wise and smart antibiotic therapy. In case when you already fix this, when the inflammatory intensity lowers, you could provide arthroscopic debridement, arthroscopic release of joint to provide better function. And in some cases, like when you have long-term inflammation of joint, the result of treatment will be poor. And even if you have, when you kill this, eliminate this microorganisms, and you have like cold joint, you could provide arthroplasty, total hip, total knee arthroplasty. So different complications are like joint destruction, dislocation, osteoarthritis, ankylosis, osteomyelitis, amyloidosis, septicemia. So amyloidosis is very rare and very not very often, and very late complication of it. So let's speak about rheumatoid arthritis. It's a autoimmune systemic disease of connective tissue that are characterized by chronic progression of process with overwhelming fitting of joints, the development of permanent deformation of joints, violation of their function. Rheumatoid arthritis characterized by proliferative destructive changes in synovial membrane, periarticular structures. Eventually, the joints are destroyed, fibrosed, in later cases ankylosed. Incidence of is 3 from 100 of population. Sex is male female, ratio is 1 to 3. And age, the mean age is 40 years. Etiology, exact causes unknown, but current hypothesis is that an initiating antigen triggers an aberrant response, which becomes self-perpetuating long after the offending antigen has been cleared. Antigenic agents, which probably act as predisposing factors, are viruses, rubella, Epstein Barr, and different genetic things common in people with human leukocyte antigen DR4, psychological stress, allergic factors, endocrine factors, metabolic. So on these pictures, you could see on the left normal synovial membrane. After initialization of rheumatoid arthritis, you could see hyperemia of capillaries and edema in synovial membrane and some narrowing of joint space. On megateres phase is increasing of lymphokine and interleukin-1 and genesis, effects of hematoxis factors, enzymes. On lymphoid phase, you could see increasing of lymphoid vessels. On aggressive phase, you could see that like a rupture of synovial membrane. These factors come to different directly to cartilage, and destructive phase when cartilage affected and subchondral bone affected also. Diagnostic criteria for rheumatoid arthritis. So there are the 7 diagnostic criteria, and if you have 4 out of 7 criteria, you will definitely say that this is rheumatoid arthritis. So first of all, morning stiffness, arthritis or swelling or 3 or more joints for more than 6 weeks, arthritis or swelling of hand joints, wrist joints for more than 6 weeks, symmetrical swelling, arthritis of the same joints, for example, 2 knees, more than 6 weeks. Serum rheumatoid factors present, radiographic features of rheumatoid arthritis, and rheumatoid nodules. Clinical radiological classifications of rheumatoid arthritis, Professor Skowrenko. There are 3 stages. The first stage is just synovitis, and the second stage is 3 phases of penetritis. That first is exudative proliferative, second is proliferative destructive, third is destructive sclerotic, and on the third stage it will be ankylosing of the joint. So take a look at rheumatoid hand. Typical for rheumatoid arthritis is ulnar deviation of the fingers and hand, swan neck deformity, and boutonniere deformity of fingers. Radiological features of rheumatoid arthritis is juice articular osteoporosis, periarticular erosions of joint margins, joint space are decreased. So different deformities, subluxations, subchondral erosions, and cyst formation, fibrosis, bony ankylosis. On this X-ray, you could see severe case of it. On this pictures, you could see juxta-articular osteoporosis just. But here you could see like ankylosis of it. First stage is synovitis. When you take a look at the wrist, you could see that here you could see symmetrical swelling of peripheral joints. When we speak about knee, is a good symptom of dilatation of patella. When you press on patella, it uses like button. So when you press on it, it will go upper like a button. The second stage, the productive destructive penetritis, oxidative proliferative. So here you can see swan neck deformity and boutonniere deformity of the fingers. On the ultrasound investigation, you could also see increase in the synovial membrane. On the second stage of productive destructive penetritis, the first phase is a proliferative destructive. The second is destructive sclerotic. When patient suffers from rheumatoid arthritis, he is not allowed to walk in normal volume as he used to. So because of this, also hypertrophy of muscles will be in this patient. Also, in this case, in this phase, you will see forced contractures and deformity of joints. In some cases, you could see subluxation. For example, in this child, subluxation of patella and contracture of knee. Take a look at this X-ray. Erosion of joint margins everywhere. Subluxation in this case. Joint space are decreased. I think it's in this case it's almost null place. In this case, you could see total narrowing and cyst formation. Take a look here, here, here. Same pictures, subluxation of hip. And in this case, you could see fibrosed ankylosis. Fibrosed and bony ankylosis and clear bony ankylosis. Difference between bony ankylosis and fibrosed, that fibrosed is painful. When patients suffer from bony ankylosis, it has no ROM at all and no pain at all. Classical presentation is systemic, and manifestation is weight loss, depression. Systemic presentation is subcutaneous nodules, vasculitis. In laboratory investigation, you could see chronic anemia, iron deficiency anemia, vitamin B12 deficiency, generalized osteoporosis, eye changes, uveitis, keratoconjunctivitis. More rare is lung affections, pleuritis. More common are heart affections, pericardial friction, effusion, arrhythmia, neuromuscular system, mononeuritis. The aim of treatment is to keep inflammatory process at minimum, keep constitutional symptoms at a minimum. The possible deformities are anticipated and prevented by appropriate splinting. And finally, surgical measures to correct the deformities, eliminate pain, and provide stability. General measure: removal of infective foci. Splinting is a functional position that helps to prevent that ankylosis anxious. Stimulation of muscles, impulsive exercises for the muscles of immobilized extremity, and improve the function of the neurological, nervous, endocrine systems, respiratory function, and function of liver. So drugs are analgesics, anti-inflammatory drugs, disease-modifying antirheumatic drugs, and steroid intra-articular injections. before injection, you must puncture and remove all inflammatory liquids. First line of drugs is NSAID, and there are some quick facts that there is no ideal NSAID. Prescribe NSAID with which clinician is familiar. Ideal is a twice-day regimen. Only one NSAID at a time because of different complications. To be tried for a minimum of 2 or 3 weeks treatment. NSAID provide only symptomatic relief. And second line, slow-acting drugs, methotrexate, immunosuppressive and cytotoxic effect, hydroxychloroquine, like flaquenil, it's anti-malarial sulfasalazine, leishmaniamide, TNF, tumor necrosis factor inhibitors, it's like AIM agent, infliximab, tocilizumab, adalimumab, etc. Soluble interleukin-1, anakinra, intramuscular gout, and cytotoxic agents. Quick facts about second line. Used only if first line fails. Continued at least for 6 months. Parallel NSAID also must be used. Choice of drugs is based on clinician's experience. Antimalarial drugs are used if proper blood monitoring is not available, and all drugs are toxic. So surgical procedures. The disease is clearly progressive and conservative measures are failing. Aim of surgery is to relieve pain, correct the deformity of the joint, reduce joint instability, improve the range of movements of the joint. So first is synovectomy. It's good in early stage and will be very effective. You could provide it arthroscopically. In the second phase of the second stage, synovial capsulectomy, electrolysis, osteotomy, and the third phase, synovial capsulectomy with arthroplasty. And this is the cases of biological arthroplasty of elbow, knee, and arthroplasty of hip. And total hip replacement in case when you have cold arthritis, in case when the rheumatoid attack is on very low side. And case of arthroplasty of the knee. Tuberculosis arthritis. It's a specific arthritis caused by Mycobacterium tuberculosis. Tuberculosis arthritis accounts for approximately 1 to 3% of all cases of tuberculosis, and for approximately 10% of extrapulmonary cases. Large joints affects much more higher than non-weight bearing joints. Usually monoarticular, and polyarticular is like 5 to 15% of cases. Clinical presentation is 5 stages. On the first is the synovitis, local osteoporosis. And second, early arthritis with marginal erosions. Third is advanced arthritis with subpericondral cyst and loss of joint space. Fourth is a more advanced arthritis. And fifth is ankylosis. Diagnostics, first of all, it's a clinic. Second, for clinic, you could take a look at these stages, and on different stage, you could see different clinic. Bacteriology is a golden standard, and you must take at least 3 samples. It's a typical X-ray triad: periarticular osteoporosis, peripheral cell erosion, and gradual narrowing of interarticular space. Difference between tuberculosis and rheumatoid arthritis is that narrowing of joint space in case of tuberculosis is less than in case of rheumatoid. Computed tomography and magnetic resonance investigation for deep diagnostic is used when you see a good picture of it, and maybe if you want to choose maybe surgical tactics of it. Useful is tuberculin skin test, PCR testing, and synovial biopsy. 5th, 6th, and 7th are very useful and very smart. On this picture, you could see cysts, narrowing of joint space, erosions, and treatment. First of all, it's drugs, NSAIDs, and specific antibiotics. Scheme of treatment you could see on this table using different splints and orthesis. And in some cases, when the tuberculosis process is lowered, you could provide arthroscopic debridement and drainage of abscesses. Thank you for your attention.